presenting a case, ma'am?
Yes.
Geetanjali, start presenting.
Yes, sir. Good afternoon to all. I am Geetanjali Priyadarshini, final year MBA student from
Sharing Varma.
Raman Mohan Kumar Mangalam Medical College, Salem. I thank IIT for providing this opportunity to present and learn. And I also thank my professors for their guidance in this case presentation. And I am going to present the case on thalassemia.
Sharing earlier.
Case history.
Geetanjali, share your slides.
Sir, yes, sir. Is it visible?
Yeah, good.
Yeah. Yes.
Lakshita, a 3-year-old female child, third born of third-degree consanguineous marriage, hailing from Karmandurai Hills from Salem district, brought by her mother, whose reliability is fair, comes with the chief complaints of abdominal distension for the past 1 year, and also with the complaints of easy fatigability, breathlessness, and abdominal pain for the past 3 days. This is the image of the child. And coming to the history of presenting illness, the child was apparently normal up to 6 months of age. Then the child was admitted for fever in GMKMCH for 8 days and treated with some IV medications and blood transfusion. On discharge, parents were told that the child was suffering from some hematological problem and may require regular blood transfusion. And there is history of abdominal distension since 1 year of age, gradually increasing, not associated with fever, vomiting, constipation, abdominal pain, or oliguria. History of paleness of palms and toes since 1 year of age. There is history of blood transfusion once in 2 to 3 months.
So with the history alone, since the child has come with all the problems of repeated transfusion, what could be your hematological problem?
Hemoglobinopathies may require regular blood transfusion or any aplastic anemia.
Apart from hemoglobin, what are other causes for regular blood transfusion?
Or any autoimmune hemolytic anemia. Sir.
Autoimmune, okay. That may not be the answer. But congenital aplastic anemias, or you can say pure axial aplasia, they require regular blood transfusion.
Yes, sir.
Okay. Is a native history of where the person hails from? Is it important?
Yes, sir. Hilly regions, the people living in hilly regions are prone for developing sickle cell anemia. Sir.
Okay. Particularly in England around Salem and Dharmapuri district, this thalassemia is quite common, especially in the hilly areas. So the person where the person hails from is very important history in these cases. Okay.
Yes,
Next.
At present, the child presented with history of easy fatigability for the past 7 days, no history of fever, no history of bleeding manifestations, no history of edema, swelling of legs, or decreased urine output, no history of any palpitations or breathlessness, no history of yellowish discoloration of the eyes, no history of passing high-colored urine.
So what do you want to infer from this? When there's no history of edema, swelling of legs, or decreased output.
Sir, there is no complication of congestive cardiac failure which occurs in severe anemia. Sir.
Okay, okay, good. Next, the palpitation and breathlessness.
It also occurs in congestive cardiac failure complication.
Okay, what do you mean? Why you ask for yellowish discoloration of eyes?
Sir, for jaundice, sir.
What type of jaundice they have?
Hemolytic jaundice, sir.
Hemolytic jaundice, good. Where do you look for jaundice?
Sir, in the bulbar conjunctiva, sir. In the palms, on the tongue, and in the palate, sir. Nail beds.
Nail beds. You're studying for anemia. Pallor.
Yes, sir. Yes, sir.
Okay, next. You can present.
No history of passing clay-colored stools. No history of itching. No history of bone pain or painful episodes in the chest, in the abdomen or fingers. No history of leg ulcers. No history of pica. No history of visual disturbances. And no history of seizures or weakness of any of the limbs.
May you ask for bone pain or painful episode in children?
Sir, in sickle cell anemia, due to sickle crisis, it may occur, sir, painful episodes. And then
Okay.
also in leukemia, in malignancies, bone pain can occur, sir.
Okay, good. Sir. What about leg ulcers?
Sir, it occurs in sickle cell anemia, sir.
Hmm. Okay. Then why you ask for visual disturbance?
Sir, it can occur in osteopetrosis and also in long-term therapy with iron chelators, visual and auditory disturbances may present, sir.
Okay. Right. And seizures and weakness of any limbs?
Sir, in sickle cell anemia, thrombosis can occur, uh, which will lead to seizures, sir.
Okay. Right.
Next slide.
Yes, sir. Past history of blood transfusion since 6 months of age. His blood transfusion was irregular, once in every 2 to 3 months due to economical constraints of traveling. The patient was advised to have regular oral medication since 2 years of age, but the compliance was poor. No history of surgery in the past, no history of tuberculosis or seizures.
Anything else கேக்குறது than a past history?
Okay, how frequently the child was advised the regular medications? But the child, the patient was advised, but the parents did not give the medication to the child, isn't it?
Yes, sir. Yes, sir.
What are the medications advised?
Sir, iron chelators may be given.
No, you can tell it in the patient's own words that some drugs are given for reducing the iron in the blood. That you can say, and the patients from parents of thalasssemic patients will be very well informed. So they know even the doses, name of the drug, the blood transfusion, its complication, everything they will be aware of it. So the reliability usually in these patients will be very good. Okay. Okay.
Yes, sir.
What surgery you wanted to know in the past? No history of surgery in the past?
Sir, any abdominal surgeries, gastrointestinal surgeries may lead to malabsorption.
Okay, next.
Yes. Antenatal history. Married at 18 years of age. Para 3, live 3. Para 1, full-term normal vaginal delivery under MCH, and the child is 7 years now. And Para 2, full-term normal vaginal delivery under MCH, and the child is 5 years of age. And Para 3, and this is this child. Interpregnancy interval is 1 year, and spontaneous conception confirmed by urine pregnancy test. And she is a registered case, immunized with 2 doses of tetanus toxoid. No history of fever or rash or swelling behind the ear during the antenatal period, or no history of irradiation or drug intake during the antenatal period.
The previous 2 siblings were unaffected. They are
Yes, sir.
normal.
Yes, sir, normal.
Okay. Okay, next.
Yes. Iron and folic acid tablets were taken for 3 months. Buchanan felt at 4 months of gestation. No history of gestational diabetes mellitus or pregnancy-induced hypertension. No history of any blood transfusion or medical or surgical illness complicating pregnancy. There was no history of antepartum hemorrhage. Natal history, it was a full-term normal vaginal delivery. It was a home delivery, and birth weight was not known. Baby cried immediately after birth. Neonatal history, birth, breastfeeding started within 1 hour following delivery. No history of neonatal jaundice or NICU admission.
Though it may not be relevant to this case, before how many hours after delivery we are supposed to start breastfeeding? What the guideline says, this may not be linked to this case.
Sir, immediately or within 1 hour following delivery, sir.
Within 1 hour. Okay. Okay, next.
Developmental history. Attain age-appropriate milestones in gross motor, fine motor, socio-adaptive and language domains, and vision and hearing are normal. Immunization history. Immunized up to age according to the National Immunization Schedule. No special vaccines were given.
What are the vaccines given up to this age right now?
So lastly, 16 to 24 months, measles, rubella vaccine and JE vaccine will be given. 16 to 24 months.
JE vaccine. Okay, it is given in IAP schedule. Government of India, we give only MR, measles and rubella vaccine.
Yes.
Okay, the primary immunization, all the doses the child received.
Yes, sir.
Okay. Can you enumerate the immunization chart?
Yes, sir.
Only
birth.
what the immunization at what age it should be given?
Yes, sir.
Till 1 year.
At birth, yes, sir. At birth, OPV 0 dose, BCG vaccine, and hepatitis B vaccine. And at 6, 10, and 14 weeks, pentavalent vaccine will be given. Along with that, the pneumococcal vaccine and rotavirus vaccine will be given. And IPV vaccine will be given. This will be given at 6, 10, and 14 weeks at as first dose, second dose, and third dose.
How
And
many weeks?
so 6, 10, and 14 weeks, sir.
10, 14.
10 and 14. Okay.
Yes, sir. At 9 to 12 months of age, MR vaccine, JE vaccine will be given, and DPT booster dose, first booster will be given. And in
No,
16
DP
to
booster.
24 months,
Booster is 1.5 years. Okay.
yes, sir. At 16 to 24 months, MR second dose, JE second dose, and booster for OPV will be given, sir. And at 5 years,
Pneumococcal vaccine is not in the national schedule actually. Pneumococcal vaccine is an optional vaccine. It's not in the national schedule. Okay.
yes, sir.
Okay.
Sir, at 5 years, and 5 years with DPT booster 2 will be given, and 10 and 16 years tetanus toxoid vaccine will be given.
Okay. Next, what are the special vaccines? You said no special vaccines given. What are the special
sir.
vaccines you know?
Sir, meningococcal vaccine, vaccine for cholera, or yellow fever vaccine.
The common.
Okay. What are the vaccines which should be given after or before? Sorry, before doing a splenectomy. In a case of thalassemia, what are the vaccines that should be given?
Hemophilus influenza B vaccine, pneumococcal vaccine, and meningococcal vaccine.
Yes, very good.
How many months before you will have to give, or how many weeks before you will have to give?
Sir, 4 weeks before splenectomy.
Before the planned surgery,
Surgery.
you will have to give vaccine. Why these vaccines should be given?
Sir,
In case of splenectomy.
the spleen normally protects against capsulated organisms.
Hmm.
If it is taken, they are prone for this infection, sir.
Okay. Okay. Next.
Yes. Diet history. Breastfeeding started within 1 hour. Exclusive breastfeeding for 6 months. And complementary feeding started by 7 months. The energy the child gets is 700 kilocalories as against expected the 1100 kilocalories. There is a calorie gap of 400 kilocalories, and there is also a protein deficit of 6 grams.
How will you take dietary history? How will you arrive at the 1000? How did you take that dietary history? What's the method for that?
24-hour recall method.
Okay. Next.
Yes. Family history. Age of the father is 32 years and age of mother is 30 years. Previous 2 siblings are of age 7 and 5 and they are healthy. No history of similar illness in the family and no history of abdominal surgery or anemia or jaundice in the family.
Okay, what family history will ask for regarding hemolytic anemias?
Sir, if it is a hereditary spherocytosis, a history of cholecystectomy surgery for cholecystectomy will be present, sir.
Okay.
Also for thalassemia, history of blood transfusions may be present.
Okay. Okay, next.
Socio-economic history. Father studied up to 6th standard and he is an agricultural coolie. Mother studied up to 2nd standard and she is housewife. Living in thatched house with 2 rooms and 2 windows. Using common toilet, common source of water supply. Belonging to grade 4 lower class according to modified Kuppaswamy scale.
Next.
Yes, sir. Contact history. No history of contact with the case of TB or COVID positive patients. Allergy history. No history of allergy to any drug or food. Shall I continue?
Yeah, continue.
Summary. A 3-year-old female child, third born of third degree consanguineous marriage, developmentally normal, immunized up to age, with history of regular blood transfusion. Since 6 months of age, gradually progressive abdominal distension and pallor since 1 year, with a poor compliance to treatment. Comes with history of EC fatigability. The probable system involved is hematological system, and I would like to examine the abdomen, sir.
Okay, you have taken a very nice and brief scene, but only thing is you could have briefed more about the blood transfusion history. How frequently, in the last 6 months, how frequently the child was given.
How many transfusions the child received so far? Should have calculated.
In the last 1 year, how many transfusions the child would have received? Did you take the history?
No, sir.
Okay, that should have been taken. Why that history is important? Number of transfusion in last 1 year. So the age of child is 3 years. How many transfusions?
Planning iron chelation.
Starting iron chelation. Okay. Okay. Proceed to examination.
General examination. Remember earlier.
Who's going to present general examination?
Sir Kirtana.
Yes.
General examination. The child is awake, alert, afebrile, pallor is present, icterus is present, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy, not tachypnic, BCG scar is seen, no signs of vitamin deficiencies.
Okay, ma'am. For pallor, where all you look for pallor?
The lower palpebral conjunctiva, dorsum of tongue, palate, palms and soles, nail beds.
Okay, according to IMNC, how do you classify?
Sir, less than 11.5 gram per deciliter is anemic, sir.
Anemia. Okay.
Okay,
Next. Why you wanted to say for lymphadenopathy? You said no generalized lymphadenopathy.
Sir, in leukemia, lymphadenopathy will be seen.
Yeah, you can see. So how did you identify that BCG scar?
Sir, a scar is noted on the left side upper arm deltoid region. It will be hypopigmented and puckering will be seen.
Yes, good. Okay. Okay, next present.
Vitals. Pulse rate is 96 per minute, regular in rhythm, normal volume and character, health in all peripherals equally, no radial or radiofemoral delay, no pulse deficit. Respiratory rate 26 per minute, abdominothoracic type, regular. Blood pressure 96 by 60 millimeters of mercury as measured in the right upper arm in supine position. Temperature is 37 degrees Celsius measured in the axilla.
Normally, what will be, how do you feel the pulse in this case? The child has come to you with 4 grams.
Sir,
hemoglobin.
Bounding pulse will be seen.
Very good. Bounding pulse will be seen. Okay. Okay, next.
Anthropometry. The observed weight is 12 kg and the expected is 14 kg. It lies between 3rd and 50th percentile and the height observed is 88 centimeter as against the expected height of 95 centimeter and lies between 3rd and 50th percentile. The mid upper arm circumference is 14 centimeter and the expected is more than 35 centimeter and it is appropriate. The head circumference is 46.5 centimeter. It lies between 3rd and 50th percentile.
How do you calculate the weight, height, and weight and height, Amma? What is the formula used?
Sir, for weight calculation, if the child is 1 to 6 years of age, age into age in years into 2 plus 8 gives the expected weight, sir.
Okay.
For height, age in years plus 3 into 5 by 2 will give the expected height, sir.
Height for 3 years. 1, 2.
What the formula for calculating height?
Height.
Sir, age in years plus 3 into 5 by 2, sir.
What are they?
Okay, others can also answer.
Others can answer. Anybody want to correct?
Can come on.
Sir,
Sir,
age in
Sir,
expected height in centimeter is equal to age in years into 6 plus 77, sir.
Yeah, that is the correct answer. So then, okay,
They
what?
only measure mid-arm circumference. The patient is
midpoint between the acromion and olecranon, sir.
Okay.
What are the other methods to measure the mid-arm circumference?
Shahir's tape is used, sir. Bangle method is used, sir.
Have you seen Shahir's
Quack sticks.
Shahir's tape? Have you seen?
No, sir.
What are the colors in there? Others can answer. How the colors in Shahir's tape?
Red, green, yellow.
Yeah.
Yes. Okay. Okay. Next slide. Next.
Mid-arm circumference. What is the impression, ma? If mid-arm circumference is less than 13.5 to 12.5, and if it is less than 11.5, how do you grade it? Grade the nutrition?
Less than 11.5, it is severe acute malnutrition, sir.
Okay.
When it is between 12.5 to 13.5, it is mild protein energy malnutrition.
Okay.
Severe
mild illa. Moderate, then mild. 13.5 to 12.5 is moderate, mild. From 12.5 to 11.5 is moderate. Then a SAM is less than 11.5 centimeter. Okay. So how to measure the head circumference, ma?
Sir, it is measured by using a non-stretchable tape. It is placed from the occipital protuberance and over the supraorbital ridges and in front over the glabella, sir.
So what is the velocity of the growth velocity of the head in up to 1 year?
Sir, up to 1 year, it is 2 centimeter per month.
No, that is for up to 3 months.
0.5 centimeter per month, sir.
From when? First 3 months, it is 2 centimeters, ma'am. Then anybody
3 to
else
6
want to add?
months, it is 3 to 6 months, it is 1 centimeter per month, sir. Then from 7 to 12 months, it is 0.5 centimeter per month, sir.
Okay. So is the head circumference normal for this child? Or is having micro or macro?
Is it normal? 46.5 in a 3-year-old child, is it normal? What is the normal head circumference for a child in 3 years age group? So at the age of 1 year, what should be the head circumference? At birth?
54 centimeters.
34 to 35 centimeters.
At birth, okay.
Okay.
1 year? At 1 year, what should be the head circumference? Others can also answer it.
Anybody else can answer?
Joseph, online? Okay, at the age of 1 year, it should be 45 centimeters. Okay. At the age of 3 years, it should be around 47. So this is in the normal range. Okay. So you should also in the exams, you should also know the anthropometric measurements by heart. You should not look at the charts and tell. At least the basic like weight, height, etc. components should be known for the first, at least for the first 5 years, you should be able to by heart and tell. Okay. Okay. Next.
Head to foot examination. Frontal bossing is present. Flat nasal bridge is present. Molar prominence is present. The oral cavity is normal. Skin is normal. Limbs and chest are normal. Abdomen distension is present. Genitalia are normal. Spine is normal.
So by looking at the face, what the abnormalities you are seeing in the face?
The hemolytic faces.
That's a broad term. What
What is?
face?
That's why she has
What the components which are seen in this face?
describe பண்ணிருக்கு. What is what your
The face.
Sir.
what is that? You already said, read that again.
Frontal bossing is present, sir. Flat nasal bridge is seen and malar prominence.
Prominence. What will you see in the oral cavity? Suppose in this hematological problem, what you can see in the oral cavity also?
Malocclusion of teeth.
Teeth will be malocclusion of teeth you can see.
There are other components in hemolytic phases which are not mentioned here. The other components is jaundice. Usually,
Eyes.
which eye, when you look at the eyes, jaundice will be there.
She
And
told the
the
general.
face will have a slate gray appearance. What's the reason for the slate gray appearance?
Iron accumulation.
Yes, it's because of iron overload, hemolysis, the skin will have a slate gray appearance. So all those are put together, it's called hemolytic phases. Okay.
Along with iron also, melanin deposition, increase of melanin deposition also causes that slate gray appearance. What will you see in the limbs or chest if you want to see any problem in thalassemia?
The fractures will be more common in these children. Sir.
Yeah, they're more prone for fractures. Any triple injury can cause fractures. Okay. Genitalia?
Sir, hypogonadism is seen
In male genital, hypogonadism can be seen. Okay. Spine sometimes. The vertebral fractures sometimes are common. So it causes severe problem. Severe pain also they can have. Okay. Next. Systemic examination by.
Sir,
Present.
Coming to the systemic examination of the abdomen, on inspection, the abdomen is locally distended and the pharynx are free and umbilical is displaced downwards. Skin over the abdomen is normal. There is no dilated will, no scar or sinus seen. There is no visible pulsation or there is no peristalsis. Hernial orifice is free and genitalia is normal.
There are no dilated veins seen.
Yes, sir.
Okay, why do you want to look for dilated veins?
Any portal hypertension, sir, to look for portal.
Portal hypertension, okay.
And SVC obstruction.
Okay. Next.
On palpation, the abdomen is no warmth and no tender seen. And the abdominal girth is 52 centimeter. Liver palpable 6.5 centimeter. Below the right costal margin, below the mid-clavicular line, it moves with respiration, firm in consistency, and round margin with smooth surface and non-tender. Spleen is palpable 19 centimeter below the left costal margin, extending to the right clavicular line, which is firm in consistency, non-tender. Splenic notch is felt, and it moves with respiration, non-ballotable, not bimanually palpable. We can't able to insinuate the fingers into the costal margin and there is no fluid thrill seen.
Okay, did you measure the liver span?
The next percussion.
Okay, next.
How do you differentiate between spleen and kidney, ma?
So spleen has splenic knots, sir,
Mm.
and it lies in the left hypochondrium,
Mm.
and it's usually can't insinuate the fingers,
Mm.
and it's non-bellotable, and it moves with respiration, sir. And the splenomegaly usually move towards the right iliac fossa, sir.
So how to differentiate bimanually? It's not palpable. So that's all. For any renal swelling.
Okay, sir.
Okay,
On
next.
percussion,
Mm.
on percussion, dullness is felt over the mass in the right and left hypochondrium, which is seen, and the liver span is 9.5 centimeter. There is no free fluid. On auscultation, bowel sounds are heard, and there is no bruit.
Okay. Next.
Coming to the other system examination, CVS S1 is heard. There is soft systolic murmur of grade 3/6 heard all over the precordial area. There is no radiation. S2 is heard. On RS examination, bilateral air entry is present and there is no added sound. CNS shows no focal neurological deficit.
What the cause for that moment? Soft systolic murmur of grade 3/6 or all over the precardium.
Sir,
What the cause for that soft systolic murmur?
it is due to anemia of low viscosity, sir, that creates turbulence.
Turbulence, okay. Usually this thalassemia children will also have a venous sound. Did you examine the venous sound? Usually these children will also have a venous sound. Okay.
Okay,
So look
yes,
for
sir.
that.
Yes, sir.
Okay, summarize the examination findings.
Sir, here spleen is usually palpable, and it is a case of massive splenohepatomegaly with anemia and jaundice, so with the need for regular blood transfusion. A case of chronic hemolytic anemia probably could be beta thalassemia majors.
Okay.
Shall I intervene?
Okay, sure, sir.
Yeah. Suppose spleen is tipped, how many times that spleen enlarged? Suppose we are palpating spleen, just tipped. Okay. So how many times spleen enlarged?
In other words, normally how
3
many times the
times.
spleen should enlarge before you be able to palpate?
Just
That's
palpable.
what.
Yeah.
3 times, sir.
Yeah, good. Yeah,
Good.
3 times. What
3
are the
times.
methods you can use for palpate the spleen?
Sir, Hackett classification, sir.
Okay. So just you explain how you palpate the spleen.
Sir, by placing the palm of the hand or the left side of the abdomen straight with the fingers, usually in the right iliac fossa, sir, with the fingers pointing towards the spleen. And the hand is kept over the right iliac fossa. And we have to move towards the left hypochondrium by
That
asking the patient to take deep
fingertips, I think
inspiration.
fingertips should move. Huh? Okay. Yeah. Okay. Good.
So by moving towards the left hypochondrium, splenomegaly can be seen, sir.
Okay. Right. These are sometimes they may ask how will you palpate the
Spleen.
kidney, and another thing is how will you palpate the spleen, and these are the common questions asked. How will you liver span? How will you measure the liver span?
It's the distance between the upper and lower border of the liver, sir.
How will you, I am asking, how will you measure the liver span?
Sir, lower border can be seen by palpation method, sir.
Good.
By keeping the fingers in the right side of the abdomen,
Okay.
with the fingers pointing towards the right subcostal margin, sir.
Good.
And patient is asked to take a deep breath. And we have to move fingers towards the liver, sir, to see the hepatomegaly is seen or not.
What do you mean liver span? Liver span. So can you do it? Yeah, can you do it in palpation method or percussion method? Liver span.
By palpation and percussion method, sir.
Palpation, I think you can't do it. Liver span. Liver span means total the liver.
Total enlargement of the liver.
Liver.
So only
It is called
percussion
liver span.
you can find the upper border of the liver.
Okay.
Yeah, how will you percussion do it? How will you make it the liver span?
Sir, by doing tidal percussion, sir.
Tidal percussion. So Any of you, please? Any other, Giranjali? Yeah.
The upper border is identified by percussion method and lower border identified by palpation, and after that we should measure the span.
How will you, that my question is, how will you percussion method, how will you do percussion?
So from the second intercostal space, we should start percussing. And
So
once
mid
the
clavicular, that's why you tell the word that mid clavicular line start with the second intercostal space. Okay. How to come down. Okay. Yeah, good. After that?
and once we have to come down, once the dullness is felt, we have to stop at that side. And to differ in tidal percussion, and we ask the patient to take a deep inspiration and hold the breath at the inspiration. And in that position, if we palpate again, we can differentiate between pleural effusion or whether it is a pleural effusion or liver dullness.
Why it's important? You are looking for the, see, selling 9 centimeter, 6 centimeter below the costal line. So why it is important liver span? Just you can palpate, you can diagnose. Why that liver span is very important. So otherwise, what are the conditions? The push down liver will be there.
So massive pleural effusion can push the liver down.
Okay, good. Okay.
So emphysema.
Good. Any fluid? Okay. One thing is any air. Okay. One thing. Okay. So it will may push down. Okay. Yeah. Please go ahead. Thank you, sir. Thank you. Please go ahead.
Thank you, sir, for interviewing.
Yeah.
This diagnosis, how are you going to proceed?
For complete blood count, we can do, sir.
Okay, we are going to investigate. What are the investigations you will advise?
Sir, after complete blood count, we have to confirm the diagnosis by hemoglobin electrophoresis.
For 1 minute. Before that, your diagnosis is not complete. You said the child is having some difficulty in breathing for the past 3 days. Isn't it? In the history.
Yes, sir. Yes, sir.
So what the cause for that? And you should also add that in the diagnosis. The child had difficulty in breathing for the past 3 days, isn't it?
Yes, sir.
EC fatigability for the past 3 days. So in the history it was there, no?
Yes, sir.
Okay. So what's the cause for that?
Sir, maybe anemia complicating congestive cardiac failure.
No, the child is going in for failure. Effort intolerance is there. So the child is going in for failure. That can be added in the history.
Yes, sir.
Okay.
Yes, sir.
What are the causes for why this child should go in for failure? The reason is the child is on irregular treatment. That's the reason why the child is going in for failure. Second thing, if there is any history of iron overload, any history of any signs or symptoms of hemocitosis there, that also you can include in the diagnosis. Okay. Okay.
Yes, sir.
Okay. What are the investigations you will do?
Complete blood count, hemoglobin indices, iron studies, sir. Then for assessing iron overload, liver biopsy or T2 weighted MRI, and X-ray of the skull and bones to see cortical thickening fracture.
High-tech, what you investigation to confirm your diagnosis.
Which we are going to do to confirm the diagnosis.
That is all the follow-up investigations. To confirm your diagnosis of thalassemia, what are the basic investigations you want? In other words, how do you rule out thalassemia? What is the gold standard test?
The screening test is Nestrov test, sir.
And
the confirmatory test is high performance liquid chromatography.
What is Nestrov test? What do you expand that?
Naked eye single tube red cell osmotic fragility test.
So what will be the result in thalassemia?
Sir, fragility will be low, sir.
Low.
Fragile.
Okay, we'll see the investigations one by one. What abnormality you will expect in complete blood count? You said the first investigation is CBC. What the abnormality you anticipate in CBC in case of thalassemia?
Sir, hypochromic anemia, sir. Microcytic hypochromic anemia will be seen.
Yes, you will have to tell the exact word, hypochromic microcytic anemia. Okay. What the important differential diagnosis for hypochromic microcytic anemia?
Iron deficiency anemia and sideroblastic anemia, sir.
Iron deficiency anemia, thalassemia, then?
Sideroblastic anemia.
Sideroblastic, okay.
One more.
Lead poisoning.
Yeah, very good. Lead poisoning also. How to differentiate all these four with your microcytic hypochromic? Can you tell each one characteristic cell for each one? For thalassemia.
Target cells.
Okay, basophil stippling will be seen in lead poisoning as well as thalassemia, as well as even in mild severe iron deficiency also will be seen. Characteristic, you tell one more.
Target cells.
Or where?
Thalassemia, sir.
Thalassemia, your target cells. Okay. Then?
Sideroblast will be seen in sideroblastic anemia.
Okay. Lead poisoning?
Okay, can you, through CBC, can you differentiate thalassemia from iron deficiency anemia? What will happen to the total RBC count in thalassemia and iron deficiency anemia? Is there any difference over there? Have you heard of Menzel index?
Yes, sir.
Now, what is Menzel index?
Sir, it is mean corpuscular volume divided by RBC count. Be decreased in case of thalassemia and increased in iron deficiency anemia. More than 13 in iron deficiency anemia, less than 13 in thalassemia.
So in case of the thalassemia, the RBC count will be increased or decreased? Total RBC count. In case of thalassemia, total RBC count will be increased because the disease causes ineffective erythropoiesis, and so erythropoiesis will be accelerated. So more amount of RBCs are produced, but they are prematurely, they will be destroyed. So RBC count will be more in case of thalassemia, whereas in case of iron deficiency anemia, it will be less. So that's an important differentiating feature between which you can see in RBC count. Okay. Okay. What is the next important investigation? In case of any hematological disease, the next important investigation you should say is peripheral smear. Okay. What are abnormalities you will see in peripheral smear?
We already discussed. Additionally, you have to say the whole jolly bodies also, along with the microcytic hypochromic, anicytus, poikilocytus, target cells, whole jolly bodies can be seen. Any importance for reticulocyte count in this case?
Reticulocyte can be increased.
It will be increasing. Any hemolytic disease you are suspecting, always you have to look for reticulocyte count. What is the normal value, reticulocyte count?
0.5 to 1.5%.
0.5 to 1% is the normal. So in hemolytic crisis, always the reticulocyte will be increased. Okay.
Okay, what is the next important investigation? Next will be to look for the
iron studies.
No, before iron study, you got to confirm.
Hemoglobin indices.
Next thing is
next to
do the
confirmative test.
Gold standard confirmative test.
To confirm thalassemia, what is the gold standard?
Sir, high performance liquid chromatography.
Yeah, high performance liquid chromatography.
You have this in your hospital. It's a very costly equipment, costing more than 50 lakhs. Do you have it in your hospital? Yes, we have. We have HPLC with us, and we are doing screening for hemoglobin. Please, I'll tell you about the project later. Okay. So HPLC is being done. In HPLC, what abnormality will be there? In case of thalassemia and beta thalassemia major, what abnormality will be there in HPLC?
Sir, HbF band will be increased. Also, HbA2 will be elevated. And HbA will be decreased.
HbA will be
decreased.
Decreased. Okay.
What is the change in HbF, hemoglobin fetal?
Alpha 2, gamma 2.
HB adult?
Yeah.
Alpha 2, beta 2.
Beta 2. Okay.
So by doing a hemoglobin electrophoresis, we can confirm the diagnosis of thalassemia. Okay. Can you classify the thalassemia?
Thalassemia major, thalassemia intermediate, and thalassemia minor.
Minor can be classified. Okay. Apart from confirmation disease, we can do HPLC and confirm the disease. Then we will have to do the iron panel to estimate the iron overload. Okay. What are the abnormalities you expect in iron panel?
When do you start? When do you order for iron investigation? Iron panel, serum ferritin levels to be monitored. After how many transfusions?
After 50 to 20 transfusions.
About 15 to transfusions and above, or near and above, you start investigating for iron overload.
Yes.
What is the investigation for iron overload? What are you going to see there?
Serum ferritin will be elevated more than 1000 nanograms.
1000 nanograms. Okay.
Serum, what will happen to serum iron and iron binding capacity?
So serum iron will be increased, sir. Also, the total iron binding capacity will be decreased, sir.
Iron binding capacity will be decreased. What will happen in iron deficiency anemia?
It will be increased in iron deficiency. It will be increased, sir.
No.
Sir,
In case of serum,
phone number மட்டும் phone பண்ணுங்க.
in case of iron deficiency anemia, what are the abnormalities seen in these three tests?
Sir, iron, ferritin and iron will be decreased, sir. But the total iron binding capacity will be increased, sir.
Will be increased. Okay.
Zero, sir.
Do you need any other investigations?
Sir, for iron overload, liver biopsy can be done, sir.
Okay.
T2 vital MRI, sir.
In liver biopsy, what would be the iron content? It is more. It is hemosiderosis. Anybody? It should be more than 2,900 micrograms per grams of the dry liver weight. Okay, for iron. That after 2 years you can monitor for liver biopsy. For cardiac iron overload, they usually have manifestations after 6 to 8 years. So you have to take T2 images with MRI. MRI T2 images can be taken to see for the deposition of iron load. What is the problem with iron overload in the heart? What all problems they can get?
Arrhythmia and heart failure, sir.
Arrhythmias, cardiomyopathy, dysarrhythmias, they can go for blocks, AV blocks. So even they can develop a pericardial effusion. So all those cardiac tamponade also can occur. These are the complications of iron overload in the heart. Where else you can get iron overload? What are the other organs affected?
Liver and endocrine organs.
Very good. So what are problems you can encounter?
Hypothyroidism.
Pancreas.
Hypothyroidism, thyroid gland can be affected. Next.
Hypogonadotrophic hypogonadism, sir.
Hypotrophic hypogonadism syndrome. Okay. Next.
Diabetes.
Diabetes mellitus. Okay. Pancreatitis can be affected. Next.
Adrenal insufficiency.
Adrenal insufficiency due to adrenal organs involved. Okay. Next. And then hypopituitarism also sometimes they can occur. These are the major endocrine problems they can encounter later in their life. Okay.
So in the investigation, you have completely covered almost everything. But only thing is, one more thing is, you have to do pre-transmission testing. You have to do blood grouping, RS checking, HIV exam. You can do all these tests for pre-transmission testing. You can do
Pre-transmission as well as post-transmission testing also you have to monitor.
Okay. Coming to the treatment, how they manage a case of thalassemia?
So we can give gluco-reduced packed red cells, sir.
So whenever you are asked about how the management of managing a case of thalassemia, you have to say the components of therapy. That is the first component is transfusion. The first one is transfusion regimen. Second is iron chelation. What is the third one? Transfusion regimen, iron chelation, other supportive care. Like vaccines you have to do, other supportive care. Lastly, you have to explore long-term permanent cure for this sugar. So in these four components, you have to discuss. So the first thing is blood transfusion. Tell me about blood transfusion. How frequently you will give? What the dose? What you do?
Every 3 to 4 months, 4 weeks, sir.
What the regimen called as?
Hypertransfusion, sir. So maintaining the hemoglobin at 10 grams percentage.
Okay, it's broadly classified as low transfusion and high transfusion. Low transfusion, you maintain the hemoglobin between 6 and 10 grams. In hypertransfusion, it is 10 and 12. In super transfusion, it will be 12 to 14 grams. More and more target depletes, more frequently you will have to transfuse. And more the iron overload will be there, so which you will have to address adequately. Apart from blood transfusion, you will have to give folic acid and chelation also you will have to give. Okay, the high transfusion regimen is preferable because it ensures normal growth and it decreases ineffective erythropoiesis and the facial deformities will be reduced. It also prevents pneumonia. It decreases iron absorption from intestine and normal development of immune system. Endocrine system will also be normal. Normal and psychological and physical well-being will be there. Better quality of life will be there. But all of the cost of iron overload. Okay.
Yes, sir.
So in your hospital, what is the regimen followed?
So high transfusion.
High transfusion regimen is being followed. Okay. So in our hospital, we prefer packed red cells in the doses 10 to 15 ml per kg every 3 to 4 weeks. We usually advise them to come once in 3 to 4 weeks. Okay. In our hospital, especially in areas like Salem and Dharmapuri, where the thalassemia cases are more, we have a center called Thalassemia Daycare Center. Okay, Thalassemia Daycare Center is there. Since you are all in COVID quarantine, you are not able to see that. So this is our daycare center, hemoglobinopathy and hemophilia daycare center. So children can just walk in the morning, get transfusion done, and go back in the evening. So they need not bunk their school, and their daily routine will not be affected. So they can come in the weekend, like Saturday when the school is holiday, they can come and get transfused and go. That's in your daycare center. So Thalassemia daycare center is right now in some areas like Delhi, Madurai, they also have these daycare centers. Okay, next component of treatment is what the next component is iron chelation. What the drugs used in iron chelation?
Name man. Iron chelation.
Sir, desferrioxamine, deferriprone and deferriprox, sir.
Deferriprox. Okay, 3 drugs are used. In our hospital, what we are using?
Deferriprone, sir.
Deferriprox. The deferriprone is not. Which has got more advantage for the cardiac? Deferriprox or deferriprone?
Deferriprone, sir.
Deferriprone is more for cardiac or iron overload. Good. But deferoxamine is a painful procedure. It has to be given subcutaneously for a period of hours, 8 to 14 hours you have to give. That's why nowadays we all prefer the oral drugs, deferriprone and desferriox.
So desferrioxamine has to be given subcutaneously, that as an infusion for 12 hours a day. So it is practically not all possible. The child has to almost live in the hospital. Or through the night, child has to be on a subcutaneous pump. So the compliance will be very poor. So we will always prefer oral drugs. Oral drugs are very effective. Right now we are using deferrioxamine. Deferrioxamine is the drug which we are using. The dose is 30 to 40 mg per kg per day, and it has to be taken orally. The common side effect which we observe in deferrioxamine is hepatitis. Apart from skin rash, transaminitis, commonly we use hepatitis. But the adverse effects are quite rare. It can be very safely given.
And to monitor the urea, creatinine, and LFT every month for these patients who are on iron chelators.
Okay, when you start ion chelation? When you start ion chelation for a child?
So when the transfusion is more than 15 to 20, or when the transfusion exceeds 1 year, we can give, sir.
Okay. The broad guidelines are this. It should be started after 15 to 20 transfusions. Usually the be around 1 year, more than 1 year. And serum ferritin should be more than 100 nanograms per ml. This is a broad guideline for ion chelation. What are the adverse effects of iron overload?
So it can lead to iron overload in liver, heart and endocrine organs, sir.
What are the common end organs which are damaged in iron overload? Organs. Just you told me. What are other organs?
Endocrine organs.
Liver, sir.
No, mainly liver.
Mainly liver, cardiac, then endocrine organs. These are the end organs which are affected mainly by the iron overload.
Can it cause diabetes?
Yes, sir.
Yes, sir.
It can cause diabetes also.
Diabetes mellitus
If
also.
it involves pancreas, it can also cause diabetes. Non-diabetes, it can cause. Okay.
By 2 years of age, after diagnosing thalassemia, liver is affected first. So liver iron content will be more. By 6 to 8 years, cardiac complications are more. In between, you can have that endocrine problems also. So annually or monthly, you have to monitor for those end organs to be monitored. So,
Okay. When you advise splenectomy for this child?
After
Shall
5
I
years.
intervene?
okay,
Hello, sir.
Yeah.
welcome.
During that's oral chelation therapy, what vitamin you will advise? Why?
Sir, vitamin C,
Why?
it converts hemocysteine into soluble form of ions.
So it's a non-soluble to soluble. So that's why one cheaper one is you have to convert use the vitamin C. So as we said, no, that's a convert the hemocysteine to ferritin. Okay. And what are the, if you're giving chelation therapy, what are the complications you have to monitor? Suppose the babies on chelation therapy, what are the complications you will expect? Or what are the system or special organs you have to monitor?
Sir, if it affects,
I think optal, you have to look for optal. Okay, so it may produce retinal artery damage, one thing. So sometimes may go for a color vision defect also will be there. Okay. And another one is hearing also, you have to monitor hearing. May go for hearing impairment also will be there. Okay, these are two things, important things you have to monitor. Okay, please proceed.
Okay. Next is when you
Thank
advise splenectomy for this child? Is splenectomy cure this thalassemia, or when you advise splenectomy?
sir, after 5 years of age, we can splenectomy.
Okay. Then what are the criteria for doing a splenectomy?
Sir, if there is hypersplenism, there is hypersplenism, sir,
Okay.
or if the blood, sir,
How will you know?
How will you know there's hypersplenism?
sir, if there is thrombocytopenia with leukopenia and compensatory expansion of bone marrow, and also the blood transfusion requirement will exceed 200 milligrams per
200 ml per
ml per kg per
kg per year. So when the requirement crosses beyond that.
So if packed result RBC transfusion is more than 200 ml per kg per year, it's not per year, it's not DL, it's per year.
Per year, that mg should be removed.
It is 200 ml, it's not mg, 200 ml per kg per year. Okay. So roughly that will be how much? The child has to be given transfusion once in 2 weeks. If the child's transfusion requirement is once in 2 weeks, it means the child is going in for hypersplenism. Okay. So before doing this, you have to do a vaccination with pneumococcal, influenza B, and meningococcal vaccine at least 1 month prior. And penicillin prophylaxis can be given lifelong for opportunistic post-splenectomy infections. Okay.
I think malaria prophylaxis also had to give because thalassemic children are resistant for malaria. They have to give malaria prophylaxis also have to give. Yeah.
In high endemic areas, malaria prophylaxis should be given. Okay. Broadly, what are the types of thalassemia you know?
Sorry, sir.
What are the types of thalassemia?
Alpha and beta thalassemias.
Okay. Have you seen patients with alpha thalassemia?
No, sir. Mostly they die in utero, sir.
Okay. Because the thalassemia is incompatible with life and they usually die in utero.
That's the cause for eye drops fetalis, most common cause. Okay.
The most important cause was eye drops fetalis. Okay. Beta thalassemia, how they are classified? Major, minor, and intermediate. What is the difference between these three?
Sir, age of presentation, sir. Sir, major will present
No,
in every life.
genetically, what are the basic effects? Basic pathology.
Sir, if both the genes producing beta chains are affected, it is major, sir.
They're homozygous. So beta thalassemia major is homozygous.
Sir. Heterozygous in case of carriers.
Actually, you can denote the beta chain in 3 ways.
3 ways.
Normally, beta. The second one is called beta 0. Beta 0 means complete absence. Third is beta plus. Beta plus means there is some deficiency. Okay, these are 3 ways in which we can denote the beta chain. So if it is beta 0 or beta 0, that means complete absence. So that case is called as beta thalassemia major. Okay.
Yes, sir.
Beta thalassemia major, what is the usual age of onset of the disease or age of onset of symptoms?
After 6 months. Sir.
After 6 months.
Why it's present only after 6 months?
Sir, until that HbF will be present. Only at that age the HbF starts decreasing and HbA starts increasing.
So why does it how does it matter?
Sir, HbF does not need beta chain, sir.
Yes.
HbA needs
HbF does not need beta chain because it's alpha 2 and gamma 2. So at the age of around 3 to 6 months, hemoglobin F will be replaced by hemoglobin A. At which time this disease will present. Okay. Coming to beta thalassemia intermediate.
So there will be some production of beta chains, not complete absence.
Okay, it can be beta plus or beta plus. It can be beta plus or beta plus. So some deficiency will be there. So at what age it will present?
Adolescence, sir.
Around the age of 10 years, it can present.
About 10 years, they start manifesting.
It will start manifesting with mild anemia. What is the thalassemia minor?
Only one chain will be affected, sir.
So you can denote that by beta bar beta plus. One chain is normal, other chain is deficient. So in that way you can denote that. So at what age it will present? It will be present in adults as mild anemia. It will present in adults as mild anemia.
Not requiring much blood transfusion.
It does not require any transfusion or any treatment. Okay. What is the mode of inheritance of thalassemia and why that is important?
Sir, autosomal recessive, sir. Sir, if there is consanguinity, it will manifest, sir.
Yes, this is a disease which is classical example for ill effects of consanguineous marriage. Okay.
Yes.
So once consanguineous marriage is stopped, the disease will not propagate. You know where thalassemia is common in India, apart from our place? Where else it's common?
Punjabis and Sindhis.
Punjab, Sindh, it's in the Saurashtra region.
Saurashtra community. Gujarat, it is more common.
In Gujarat, it is more common, especially in the Kutch region of Gujarat, it's more common. And they have successfully eradicated the disease there. How did they eradicate? They almost successfully eradicated the disease there. And in another few years, we will also be eradicating the disease. Right now, our government is doing a project called Hemoglobin Project. What we are doing is, we are screening all the adolescent boys and girls for the carriers. In all the tribal schools and the tribal area, hilly areas, our government is doing this screening. For the screening, we are using NESTOP. If the NESTOP is positive, then they are sending the child to us where we are doing hemoglobin electrophoresis. If the boy or the girl is found to be a carrier, we'll genetically give genetic counseling and advise them not to marry another carrier, so the disease will not propagate. So in another few years, probably the occurrence of thalassemia itself will decrease in our country, in our state. This is a massive project of National Health Mission, and people are ambitiously working for the project. And our hospital, along with the Road Medical College, we are all part of the project. So we are following what Gujarat has done. Okay. So
What
this
is the
hemoglobin project, which is happening in our district. Okay. So autosomal recessive mode of inheritance is there. So you will have to advise genetic counseling for them. You have to advise genetic counseling, not to consensus marriage. Okay. If two carriers they marry, what will happen to their offspring?
So there are 25% of inheriting the disease.
Another 25% will be normal. Another 50% will be what happens?
Carrier states, sir.
They will be carriers. Another 50% will be carriers.
carrier state.
So in this particular case, you said the two siblings are normal.
That's the
First two siblings are normal in this case, isn't it?
Yes, sir.
Yes. So what you are supposed to do is you are supposed to do carrier testing by NESTOP. You have to screen these children for NESTOP, and if they are found positive, you have to do a screening.
Yes, sir.
With HPLC and find out if they are carriers. Maybe one of them may be a carrier. Okay. So
Yes,
that's
sir.
also we should include in the treatment.
what is the permanent treatment or the
Hematopoietic stem cell transplantation.
transplantation is being. So where they are doing here in our place?
CMC Vellore.
CMC Vellore. Okay. Now other private hospitals in Chennai, near
Yeah, we are doing. Coimbatore, we are doing.
Coimbatore, they are doing. Narayana Hridayalaya, they are doing.
Yeah.
KMC, they are doing.
AMCH, they are doing. Coimbatore, where else, sir?
Yeah, we are KMCH only we are doing.
AMCH, they are doing. Even Ramakrishna, they are doing, sir.
I do. As per my knowledge, not doing.
Uppusamy Naidu?
Not doing. Not doing.
Not doing. Okay. So they will know the cost of the bone marrow transplantation. Private.
So the cost of BMT, what they quote in Bangalore, it's around 20 lakhs. It's around 20 lakhs, and that 20 lakhs is offered through Chief Minister's Comprehensive Health Insurance Scheme. You have to remember the scheme name. It's an important thing. It's offered to all poor children with thalassemia free of cost. Chief Minister's Comprehensive Health Insurance Scheme. It is offered through the scheme. And Coimbatore and Bangalore, Chennai, CMC, all are empaneled in the list. So we are referring children there, and it's being done free of cost. Before that, Apollo Hospital Chennai was a major partner for thalassemia, but now other hospitals are also included.
What are the complications of thalassemia?
Failure to put on weight and height.
Growth retardation.
Infections are common in this. So, and bone marrow expansion followed by cortical thinning. Since they require regular transfusion, infections are common, like bone infections. And iron overload complexes.
What are the blood transfusion infections you want to monitor?
Hepatitis B, hepatitis C, HIV, syphilis, and malaria.
Okay.
So these are broadly the complications. Anemia,
CCF, psychosocial disturbance.
Psychosocial disturbances. These children have lots of psychosocial and emotional disturbances. Okay. So that has also be attended.
And recurrent fractures can be seen. Recurrent fractures can be seen. They come with recurrent fractures, some children. So that is also there. And the complication, other complications with the iron chelators related to iron chelators, where they have to be submitted for auditory examination once in a year, ocular examination once in 6 months. So all these things they should be monitored regularly, frequent intervals. Every year they should have investigations done for your blood transfusion related, the HIV, hepatitis B, hepatitis C, all those things should be investigated once in a year.
These are the complications related to iron overload, endocrine disturbances, thalassemia, hypothyroidism, hypoparathyroidism, adrenal insufficiency, hypogonadism, delayed secondary sexual characters, osteoporosis, cardiac dysfunction. These are the complications related to iron deficiency. So, a child with thalassemia, you have to monitor them. You have to offer a holistic treatment to them. Not only you have to correct anemia, you have to give a complete cure or complete care to the child. So these are things which you should do in the monitoring. Start asked about monitoring. These are things you will have to do. What is SMR?
Sexual maturity.
Sexual maturity
SMR
rate.
training and analysis should be done every month. You will have to look for delayed puberty, and it is there, it has to be attended. And the hemoglobin should be monitored every month, pre and post transfusion, and blood-related infection should be monitored. LFT and RFT should be done if the child is on iron chelation. Apart from them, you have to do the eye examination, audiogram, serum calcium annually, and endocrine examination should be done as and when necessary. So the key messages will be thalassemia will be definitely a long case for you. Definitely be a long case for the examination.
What do you mean by thalassemia, ma? What is the anybody? Why that name thalassemia was coined?
See, thalassemia is common in the
Mediterranean Sea,
Yeah,
Mediterranean
thalassemia is
region.
the Greek word. The thalas means sea. Very good. Anemia is related to blood. That is why it is called as thalassemia. It is more seen in the Mediterranean and Southeast Asia. It's very more common. In India, there are almost about 1 lakh patients of thalassemia.
So thalassemia means sea, anemia means
related to blood.
So that's why thalassemia. So thalassemia will be definitely a long case for you. We have plenty of thalassemia cases. We have more than 75 to 100 cases involved with us. They are getting treatment in our hemoglobin daycare center. So definitely it will be a long case for you, especially for students from the Salem, Dharmaburi, Theni, Madurai. This way we have plenty of cases. So they are our frequent visitors. There will be a definite case for you in the exam. Okay. So the key messages will be: it's a very common disease in India. Diagnosis should be established during infancy. Current protocols of therapy have improved the survival and quality of life. Before some 10-15 years, the life expectancy of these children was very short because they don't give any iron chelation and they succumb to the disease. But now, with improvements in care, their survival is almost equal to any other child. And bone marrow transplantation should be taken. Complete cure should be given to these children as and when possible.
Yeah, why that thalassemia major less 6 months? Why is less common? Why the clinical presentation? Which one?
HBF, sir.
Why that? Because of HBF, what happened?
Sir, in HBF, there will be no beta chain.
So, what are the components of HBF?
Sir, alpha 2 and gamma 2.
Gamma 2, okay. So that's why nowadays they're concentrating that increasing gamma 2, that's using hydroxyurea butyrates, okay. So they make the that's a gamma chain to increase gamma chain. So that's why they can convert into the some intermediate or minor type. So now they're planning for gene therapy also. So they are increasing HPF part. That's fetal hemoglobin, increase fetal hemoglobin. So then future strict that they can convert the major into the minor type. So that means that longevity and you can reduce the blood transfusion. Okay, if you are converting to the increase HPF part, that means increase gamma chain, you can definitely reduce the blood transfusion. That's why they're trying for gene therapy also. And another thing is we're using drugs like butyrates and hydroxyurea also they're using. Okay.
Yes, sir.
Hydroxyurea is more useful for treating thalassemia intermediate and minor patients. And now they have started using for even thalassemia major. As sir said, to reduce the blood transfusion. But we have to monitor them on, if we are starting the patient on hydroxyurea, you have to monitor for their side effects strictly. We have to monitor monthly their counts, blood counts to be, since it's immunosuppressant. So you have to monitor, and a lot of toxicity is being encountered. But still, it has a long way in helping this thalassemia children. Now they have started using hydroxyurea in our patients also. A few patients for major cases, they are being doing hydroxyurea here also.
So important thing is any baby less than 1 year coming with not responding to oral iron therapy, you have to think of thalassemia. Okay. Another thing is they are coming with some endemicity also, and particularly in Badagas community, some particular community also they are having increased thalassemia. So wherever their place of the coming, one thing important, and that representing community also very important. So not responding with the oral iron sometimes may think that iron deficiency also. Not responding to oral iron also, you have to always have a suspicion, and early intervention, early control of anemia, and that's avoiding overload of iron. I think the longevity we can prolong. Nowadays we are having, as already discussed, the stem cell therapy is a very important thing, and even bone marrow transplant also, that's a viable thing. So I think it's a lot of things are coming up. Yeah.
And folic acid supplementation they require regularly. For thalassemia patients, you have to give folic acid supplement also along with other supplements, vitamin D, vitamin C, and multivitamins, the B complex. Along with that, folic acid can be given. Any other questions from the student side?
Usually the chat box, they'll ask the questions. I think nowadays they're not students asking, not asking.
They're not asking.
Yeah.
Can you tell us the numbers, sir? How many people are watching this?
One is that YouTube also, they'll some YouTube also they you use it, and you can maximum you can go 100. Yeah.
Sorry.
Okay. Okay.
Okay. Yeah, it's a very different experience for us, sir.
The different experience.
So we are to reach out to our students in larger extent. It's a totally different experience for us.
Okay. And Dr. Sambathanan, any comments, please?
No comments. It is really, I think it is very beneficial for the students in this COVID era. Because so many subjects every year, every week it's being discussed. I don't think you can get from any other platform, this learning platform. So it's been a very good initiative and benefiting the students. So after the exam